Mendelson syndrome, also known as aspiration pneumonitis, is a chemical injury to the lungs that develops following the inhalation of gastric or oropharyngeal contents into the lower respiratory tract. This condition is distinguished from aspiration pneumonia, which involves subsequent lung infection. Aspiration occurs when material from the oropharynx or stomach enters the airways, often during decreased consciousness or procedural sedation. The fundamental mechanism of injury in Mendelson syndrome is direct chemical damage to the tracheobronchial tree and alveoli from gastric contents. Factors that increase the likelihood of aspiration include increased intragastric pressure, reduced tone of the upper and lower esophageal sphincters, and diminished protective airway reflexes. Common causes of reduced lower esophageal pressure are pharmacologic agents, hormonal changes such as increased progesterone, and the use of opioids or anticholinergic medications. Injurious aspirate is typically acidic, with a pH less than 2.5, and a volume exceeding 25 milliliters is particularly hazardous. Risk factors for aspiration pneumonitis can be categorized into patient, procedure, and surgical factors. Patient-related risks include a full stomach, non-adherence to fasting guidelines, use of opioids, pregnancy, increased body mass index, distended abdomen, gastroesophageal reflux disease, decreased consciousness, and chronic neurological disorders. Procedure-related risks are the induction of anesthesia with an unprotected airway, inadequate depth of anesthesia during airway instrumentation, neuromuscular paralysis, and improper positioning. Laparoscopic abdominal surgery, manipulations that increase intra-abdominal pressure, and emergency procedures further heighten the risk. Fasting guidelines recommend at least 2 hours for clear fluids, 4 hours for breast milk, and 6 hours for solid foods. The clinical spectrum of aspiration pneumonitis ranges from asymptomatic presentation to acute respiratory failure. Common signs and symptoms include cough, wheeze, crackles, dyspnea, visible soiling of the airway, tachypnea, tachycardia, decreased lung compliance, hypoxemia, and cyanosis. Systemic manifestations such as leukocytosis, fever, and hypotension may occur even without bacterial infection. Chest radiography often demonstrates diffuse infiltrates, typically most prominent in the right lower lobe when aspiration occurs in the supine position. Prevention of aspiration is an essential aspect of care for patients undergoing sedation or anesthesia. Key preventive measures include proper fasting, use of prophylactic antiemetics, adequate pain control, and the application of rapid sequence induction with pre-oxygenation and cricoid pressure. Suction should be readily available, and bag mask ventilation is minimized or avoided. If ventilation is unavoidable, small tidal volumes with pressure under 20 centimeters of water are recommended. Use a cuffed endotracheal tube for airway protection when necessary, and consider prokinetic agents before induction and extubation in high-risk patients. Extubation should be delayed until protective airway reflexes have returned. Avoidance of nitrous oxide and minimization of opioids are preferable. Immediate management consists of minimizing further aspiration. For patients who are awake, suction the airway and place them in the recovery position. If the airway is compromised, secure it with an endotracheal tube and clear the airway using suction. Administer 100% oxygen and provide ventilatory support if required. Continuous positive airway pressure may benefit some patients. Subsequent management includes gastric decompression with a nasogastric tube, chest radiography to assess lung involvement, and critical care referral if warranted. Bronchoscopy and lavage may be considered in selected cases. Chest physiotherapy is used as indicated. The use of corticosteroids to limit inflammation remains controversial, and routine administration is not supported by consistent evidence. Antibiotics are not indicated unless there is evidence of secondary infection or aspiration of clearly infected material. Possible complications of aspiration pneumonitis include acute respiratory distress syndrome, development of aspiration pneumonia, formation of pulmonary abscesses, and cavitation of affected lung segments. The mortality rate of Mendelson syndrome varies between 10 and 30%. Outcomes are improved with early recognition and rapid, appropriate intervention.